The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. After learning about the initial assessment and early management of Sarah and her burns in part 1 of this episode, we now move on to part 2, focused on the surgical and psychosocial management of burn patients.
Let's transition to surgical management, Dr. Kirby. Could you speak to the timing that Sarah may need surgical intervention, operative steps involved, overall considerations for wound care, etc.?
Sure. So for all patients with significant burns, you want to seek early surgical consultation. Those burns should be assessed for their extent and their severity, their depth, any associated changes going all the way back to their circulatory and neurologic assessment. They should be cleaned. They may start developing early vesicles, bullae, or blisters. We selectively choose to either leave those in place or to rupture them. But if we do, I typically remove the top but allow the side walls to collapse down and almost autograft in place. They have to be watched that they don't become infected. They usually respond very nicely to local management and local antimicrobial dressings. In general, we want to assess that patient's tetanus status, make sure that they are up to date and it's supplemented both for thermal burns and also to cover at frostbite, all of which are tetanus-prone wounds. And then we want to provide that frank areas of burn necrosis and non-viable tissue are removed, that peripheral circulation is maintained, especially in this particular patient where she might have circumferential burns of either her fingers or hands or her arms or elsewhere in her extremities, that sometimes earlier eschorotomies need to be performed with longitudinal incisions to allow for good peripheral perfusion of the tissues. And then in consultation and referral with your regional center, you can work out both immediate care priorities, the type of dressings you're going to start off with, typically a topical antimicrobial, and their long-term follow-up with that regional center. In general, we want to get the patient's burn wounds assessed, cleaned, and then dressed with a topical antimicrobial and a moist supportive wound dressing that over time will help them heal in. And the only caveat that I would add is that if you're going to do an early transfer, to work in consultation and referral with your regional burn center, because if it's going to be a short transfer, they may want you to just use clean, dry, even sterile dressings so that they don't have to strip off any topical ointment, some of which are opaque, like Silvadene, because that will make their burn wound assessment more difficult and more uncomfortable, if not painful, to the patient. So that's something that you can agree upon. In general, once you get the local burn wounds dressed, that will contribute to the overall pain management of the patient, which we should be mindful of with judicious use of IV, if not oral medications in the appropriate settings to keep the patients comfortable, to allow you to do a good neurological exam, and to care for them in a thorough manner.
Yeah, dressings are really the mainstay of prevention of wound infection and management of burn wounds in general. And for the typical burn patient, they should be changed about 1 to 2 times daily for the first few days or so. Speaking of the first few days, how early is early excision and grafting, Dr. Kirby?
So this is a judgment call, but in general, you want to pursue tangential excision of significant burns as early as the patient's resuscitation response will allow. You want to get the patient stabilized, and then you want to remove the ongoing excitement and stimulation by removing, tangentially excising that burnt tissue so it doesn't continue to rev up the patient's host inflammatory responses, which is really a hallmark of what sets significant burns apart from other traumatic injuries. So you'd like to get that done in the first several days, or if not the first day, as soon as the patient is stable. And then you want to work within that patient's burn physiology so that any of the tangential excisions don't exceed it, so that the patient can tolerate it, so that you do as complete a job as possible, that you're attentive to the patient's thermal dysregulation, as these patients may get hypothermic. You stay attentive to the amount of burn, wound debridement, estimated blood losses, so that the patients remain stable and you can do a thorough job. Earlier removal will also allow you to place earlier graft placements or other skin substitutes before over-colonization or even infection sets in, so that you get a better graft take of those fenestrated split-thickness skin grafts or skin substitutes, so the burn wounds can be adequately cared for with an eye toward healing.
Perfect. I was reading some new data about the use of TXA in severely burned patients. Do you consider that for your patients?
So we do for when it's associated with other serious bleeding, especially bleeding where the long-term effects can be catastrophic, neurologic bleeding. However, I think we all have to watch the evolving literature to see where TXA is truly indicated.
Yeah. My understanding is that at this time there isn't a clear sense where the mortality benefit may lie for TXA. But thanks for the insight. Speaking of mortality, we know that mortality for the severely burned patient, like many patients that are critically ill, is bimodal. Death typically occurs immediately or soon after the injury, or later from latent complications, most commonly sepsis. When taking care of someone like Sarah with severe burns, what other critical care needs do they require to minimize their mortality after the acute phase is over?
Great question, and you're correct. This is where the ongoing advancements of both burn and critical care have really made an impact to diminish mortality over the arc of the patient's care. So in addition to the initial resuscitation and surrogate endpoints to see that resuscitation is going well, and early tangential grafting, and enhanced ways of maintaining oxygenation as well as perfusion, we have to attend to her critical care needs, which include nutritional priorities so that her body can heal. We prefer to highlight the use of early enteral and continued enteral feeds with minimal interruption for serial debridements and wound care, as well as ongoing maintenance for her volume needs to maintain her kidney function and urinary output. We want to have procedures in place to minimize the potential for infection and watch that her wounds are healing in, beginning to regranulate, if not re-epithelialize, as well as looking for signs of infection that she's not incorporating her grafts, they're sloughing off, she's developing increased drainage, pain, or erythema, all of which may be indicative that she's picking up an infection. And the American Burn Association, as well as the Society of Critical Care, if not the Committee on Trauma from the American College of Surgeons, actually has great resources that will complement the WashU manual in terms of specific criteria, culturing, and what to look for a patient developing either burn wound infection or burn wound sepsis, and appropriate interventions from surgical cleaning and further debridement, as well as antibiotic use and ongoing critical care support.
Yeah, one thing that always stumped me while working in the ICU was really the overlap between just a severely burned patient and the septic patient, given that burns are such an overwhelming inflammatory state and create such a huge response. Again, I refer listeners to look at the ABA criteria for burn sepsis in adults. You could also find some of this in the Washington Manual of Surgery. Well, that was a lot to unpack there, Dr. Kirby. The other thing that surprised me, I should say, is this nutritional requirement that burn patients have, the hypermetabolic state that we call, and how much the body really needs to heal from such an injury. And for many patients, that nutritional requirement remained increased for quite some time, sometimes even over a year after the initial insult. For our listeners, long-term, in addition to nutrition optimization, many of these severely burned patients will require intensive rehabilitation as well as psychosocial support. So for patients like Sarah, in our case, this holistic approach is indeed very vital for reintegration into society.
Yes, you're correct. So a biopsychosocial model will allow you to attend to all of these details. And you're correct, even after we get through her acute hospitalization, she may have ongoing nutritional needs, micronutrient needs needing supplementation. Especially in younger patients, she may have difficulty resetting her homeostatic thermostat, where even in the clinic, she'll come in with ongoing elevated resting heart rate that might need further interventions or assessment like beta blockade so that her hypermetabolism response to her initial burn is properly attenuated over time. And then, as you mentioned, there are psychosocial aspects to burns, especially burns of the face or burns that alter a patient's functionality where they can't go back to their original lifestyle, if not their original work. And fortunately, there's wonderful resources usually available throughout the United States through the Burn Survivors Network, as well as multiple patient support groups available online that tend to meet locally and regionally and have a national framework to assist patients as they move from their acute hospitalization all the way through their rehab, all the way through the integration into society. And one of the really wonderful things about the WashU manual is that it highlights the long-term regional commitment here in St. Louis with all of the stakeholders. We're very lucky that our commitment to patients of burn injury as well as larger trauma injuries is really something that it's wonderful to be a part of. And your listeners can take advantage of.
Perfect. Yeah, indeed, it's a multidisciplinary and multi-organizational effort, and it requires a blend of acute medical, surgical management, and this comprehensive rehabilitation, as we talked about. Thank you, Dr. Kirby, for taking us through Sarah's case, and I hope that for our listeners, it sheds some light into the advancements that we have in burn care and the hope that exists for burn survivors.
Thank you for putting this all together. I think that this has been informative and hopefully will inspire great care for our listeners, that they can help patients get through very difficult times. There's a lot of wonderful information in the WashU manual, and you can check out both the WashU manual as well as the references for the literature, both the published literature as well as the online references that we've given you for all of the stakeholder professional societies to help you really advance the care by listening to today's episode.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.